Dr. Aamer. He is currently serving in Aga Khan. I wish he was serving at Lahore with us in Punjab Institute of Cardiology. That would have been fantastic for us to learn. And his enthusiasm and desire to reach out every day is beyond explanation. From where does he get that energy? I hope it is not from a hypertensive episode that he keeps getting every day. May I request Aamer to kindly come up.
Thank you, Professor Bilal. So I have the task of talking about the hypertension guidelines. I have the chair who's encouraged us to go from the 3rd guideline document to the 4th guideline. It's not too well read, but let me assure you that it's quite well referenced and it's simple to follow. So I have nothing relevant to disclose. So BB trends show a clear shift of the highest blood pressures shifting from high income countries to the low and middle income countries. And the problem is that the low and middle income countries like us, a lot of international guidelines were quoted over here. We try to follow those guidelines, but remember those guidelines are built for their own infrastructure and they've got a very robust infrastructure. It will be very, very difficult to translate. So today I'm not going to go into a lot of detail of management of hypertension, but just show you data that we have, local data emerging that can help us bring the blood pressure control. Now, guidelines, we speak of guidelines. What is a guideline? Guidelines basically are business driven documents, and the business people, just like हमारा जो crisis management comes from the cockpit of the airliners. Similarly, guidelines come from business models where they go to the grassroots levels and जो उनका lowest level worker होता है उसको empower करते हैं through a algorithmic approach so that they can tailor the need to the patient or their customer and create satisfaction and control and whatever. So they don't have to make large loops to come back and decide what they want to do. So algorithms are very, very important. Now, so A is, for example, in our case, hypertension, then there are rules that will apply, and then there are situations 1, 2, 3, 4, and then there are paths, dotted paths that you can take to reach point Z. And then, of course, there is an algorithmic guided intellectual and scientific freedom that the worker at all levels can, be it the general practitioner, be it the consultant in a tertiary care hospital, or be the health minister, can exercise. So for hypertension guidelines, community level approach, we should empower the healthcare workers. We should have national programs, which will be tools that we use. We should ensure delivery and measure outcomes. If we are not measuring outcomes, it's useless. And then tailor treatment plans, cross-link programs. We've been talking about cardiometabolic, cardio-diabetic. We've understood, and it's not today, for the past 2 decades since I've been in cardiology, I've seen that lipids affect blood pressure affect diabetes, they all are interrelated. So cross-linking programs is very important. Ensure control, which is the outcome. And of course, local relevance is very, very important. A lot of medicines that we use over here will not be used in the West. So we need to understand that. So we know the prevalence in the adolescence is coming up to pool prevalence is about 26.34%. Similarly, 46.2% prevalence of hypertension in our urban and rural population. It's a massive problem. And of course, we've been given cutoffs and we are used to following cutoffs. It's not that it's new to us, but do we हमें speed limit 120 होती है, we drive at 130, despite the fact that we know that every 5 miles per hour increase is associated with an 8% increase in highway fatalities. But we do. So we have numbers, we don't follow those. And the problem is, we believe that we will fail when we apply guidelines. And it's because our clinics are structured in such a way that we give 5 minutes to our patients, and then how can we talk about lifestyle modification? So lifestyle modification, and we are not trained to do that. Similarly, hypertension is an asymptomatic disease. We give drugs, we cause symptoms by creating complications from 0 to 10%. And of course, physicians are too busy to educate themselves over a period of time. Now, if you look at this, and I asked you to choose which therapy will you choose, pill A, pill B, and you look at the drop in blood pressure on the right side of the panel, each one of you, I'm sure no one will choose other than A, because A drops the, causes the largest drop in blood pressure, and it's a sustained drop. And what is that? It's weight loss only. Rest of the drugs, all the drugs that we use, good drugs, good combos, are not dropping blood pressure as significantly as your lifestyle modification, or to be specific, weight loss of a significant nature. So in the Pakistan hypertension guidelines, which will remain as such, we have readdressed, and this is from the JNC 7. It's the most comprehensive table which speaks of sodium, weight loss, exercise, and it shows a benefit across. Look at the right panel. Blood pressures are being dropped. Now, the problem is, why do we not believe in weight loss? Because weight loss has got a lag effect. You lose weight today, blood pressure is not going to go down today. It will take up to 6 months to 1 year, and then it will drop. So we don't have patience. So our guidelines have suggested step 0, step 1, and step 2, which is first is educate and create awareness, which we are doing right now over here, and at a household level. Then step 2 is recommend, and this recommendation is that you follow it, and you close the loop by seeing that it has been followed. And step 2 is it is enforced, and you have programs. Now, we do not have this infrastructure across cities in Pakistan, but that's what we should be working towards if we need to control or make a dent over time. Hypertension is not going to kill today. जो आज मर रहे हैं वो पिछले 30 साल से affect हो रहे हैं. So we're going to save someone 30 years down. And this is our algorithm, and I'll give you an example of one, and we will add this thing to it. We were at that time in 2018, for low levels, we just suggested start with the low dose of 1 or a moderate dose of 1 pill. But that it's counterintuitive now, so we are recommending, just like the International Society of Cardiology, International Society of Hypertension, that 2 low doses of 2 drugs. Now, you don't find low doses in a fixed dose combination. So if you're going to start, you have to start with a combo separate pills. Like 2 milligrams of prindopril will not come in a combination, fixed dose. But the ultimate goal is to go to fixed dose combinations. Okay. And we are suggesting going to 130 by 80, because across the board, no matter which trial you pick, look at upfront or post hoc analyses or meta-analyses, 130 by 80 is a significant number. If you can achieve that without causing harm to the patient, then there is benefit across the board, even in octogenarians, 80 years old, or the very elderly. Okay, and this is our simple table, and we've all seen that you start with an ACE ARB long-acting calcium channel blocker, then you go to a thiazide type diuretic, and then if it's resistant, you add spironolactone. Now, the only thing we will add over here in the new guidelines is start with low doses of 2 drugs, even when it is simple hypertension, other than people, as has been specified, 80 years old, postural, getting up, dropping blood pressures. Over there, you can go with a low dose of a single drug, but that's a very, very small group. Similarly, sacubitril valsartan is making a dent in preserved ejection fraction as well, and it is a good hypertensive. When compared to olmesartan or other ARBs, it has significantly shown to drop blood pressure. Now, it is not part of the guidelines. I've just put it over here because maybe not in this guidelines, but in the next guidelines, it will make a mark. In the Paragon heart failure trial, in a post hoc analysis where 95% of patients were hypertensive, there was significant improvement in resistant hypertension. So they could bring down the number, whereas the number could not be brought down by conventional methodology. So this is something that probably we will be addressing in the future. And of course, spironolactone is for resistant hypertension. And if you have resistant hypertension and you give spironolactone and even then you are uncontrolled, it's called refractory hypertension. And for that, there are drugs, like you can add doxazosin to the bisoprolol, and then go with alpha blockers and other stuff. Over there, probably Arnie's and or the sacubitril valsartan combination will make a dent. So I'll just take you through a case. So it's a 53-year-old man. A lot of people in this hall will be around 50 plus. BP checked according to protocol. So the first index event was 3 readings, first discarded, the second and third averaged, blood pressure is in the hypertensive range. You don't treat, as Fawad was very rightly suggesting. Diagnosis itself is a very tedious prospect, and it has to be done properly. Otherwise, we will end up treating and under-treating and over-treating a big chunk of patients. Then the next visit will be the first visit, and on that visit also he has average of 2 readings of 150 by 90. Then the second visit, again he has the same, and at that time he got all his tests done, and his fundus exam shows AV nipping and cotton wool spots, which are signs of hypertensive change, which means that there is hypertension mediated organ damage setting in. ECG shows borderline LVH, and of course there's microalbuminuria. So across the board, this blood pressure at 53 is causing hypertension mediated organ injury. So what to do? So we'll go with step 1. Lifestyle modification now becomes, because it is with hypertension mediated organ damage, it will overlap rather than be in a series. Otherwise, if it was pure simple hypertension, low blood pressures, no target organ damage, you would give time up to 12 weeks, and then go with medical therapy. But over here, you can start medical therapy and go with low doses of 2 drugs, and then see. Now, sometimes you give low doses of 2 drugs and the blood pressure is very controlled very well. Others, you have lower blood pressures, but they don't get controlled, and that is why hypertension is a hybrid animal. It is not the same in all cases. So somewhere you will just need 2 drugs, somewhere you will need 4 drugs. So the milieu is different in both these patients. So in this case, we'll start with low dose drugs. Now, what to do further? Now we cross-link all the programs and we bring in lipids. So his lipids are definitely up. LDL being a target is 180. HbA1c again is a number, is where you don't want it to be. You've started him on moderate doses of 2 drugs, which is a good combination. But after doing this 4 weeks, blood pressure is still up. What do? Do you escalate to maximum doses of these 2 drugs or add another? And that's where room is still open and you can tailor therapy. Each one of us may be different in this. But remember, going with fixed dose combination. So try to go into fixed dose combination as quickly as possible, because that is what ensures compliance. And compliance is important for control. Then you calculate now the ASCVD risk. This is, I have put over here because we use it a lot, and it's a very easy score to use. Otherwise, there are Interheart, Framingham, whatever you have on your phone you can use. Interheart probably is more reflective, Framingham is, but ASCVD, they made amends. So we can do that, and in this case, the current risk of 10-year risk of having an event is about close to 14%. So it's intermediate risk. Optimal risk for the age should have been 2.9%. So he's significantly at a higher risk. What do we do next? We can get a calcium score. It's a simple CT scan, not a very expensive test. It will tell you whether the calcium score is what the number is. And if the number is more than 100, you can add aspirin and cause, over here, it will be a soft indication for a secondary prevention. And of course, go high on the statin dose, which you would have started on 180, and bring the target to less than 70, as you would do in coronary artery disease if the calcium score is 100. So now hypertension being the pivot, because it's the most obvious risk factors for coronary artery disease. If you can pivot everything around it, I think it will make a very good structural fix for management. This is just to show the international, it's already been shown. So data even in the elderly has been suggested that if you go with smaller doses of more meds, it led to a larger decrease than compared to when you're going with higher doses of a single dose. This is even in the elderly people who have stiff arteries and where blood pressures can boomerang up and down. And Sohail Khan also mentioned Kaiser Permanente, and I'm happy that he was someone who's referenced it also, because I've always been referencing this. This group in the private group in the United States has shown BP control rates of 90% plus. And this is the model private institutions or private mega structures like the AKU Foundation has roots all over Pakistan, can use. And so over here the patient is the center. What they've done is they've shown dedication, they've shown clear commitment on paper, and they've used all their resources, and they have caused an enabling environment to deliver, and that's how they have been able to produce 90% control. Now, can this be done in a public setup in the United States where they have been able to do that? Oh, I'm sorry. So Kaiser Permanente, they have created a registry, which is very important, which we should be doing. They have treatment algorithms which are fixed for the entire their setup. They cause regular follow-up and pep up their patients, and that's how they make sure that adherence is there, and they're using fixed dose combination pills. So I think we can learn from them. Now, not only permanent private health setup has done that. In the US, the veterans, and veterans are like us, those who have been to the United States know that the veterans hospitals are no better than our hospitals. And they have shown, they've used resource, again they've used guidelines, they've used algorithms, practically reproduced what Kaiser Permanente have done in North Carolina, and they have shown controls, raised the controls from 76.3, from 45.7 to 76.3%. In a public setup, it's amazing. So this is where we stand. This is our paper. Tazeen Jafar is the lead, and in the trial, this is reflective of Bangladesh, Pakistan and Sri Lanka, and we are all nearly in the same setup in the low middle income countries, and the control was 58%. In Pakistan, specifically in the rural areas, it was 70.6% uncontrolled blood pressure. So we have a very uphill task to do. And we have again shown, we are always looking towards the West. We have shown in the trial, this is the urban COBRA, and then we did the rural COBRA trial also. It was a smaller trial, but it was a very tedious, meticulously done trial, and we showed that if we gave home health education to the households, we trained the general practitioners in that area annually, we caused a significant decrease in blood pressure. And I've not added that slide over here. There's a echo arm of this study in which we did community echoes. We reported those, and it was sent to the Duke Center Echo Lab, and they vetted those, that they were rightly done, and we showed that the LV mass index improved with this control. And this effect, although attenuated a little, spread over and across 7 years. So in our own population, both in the rural and setting, we have shown a model. And this should be presented to the government, and the the government should be having public-private partnership. And so this was done in Karachi. It was done in Thatta, Gharo. These are the areas where people were benefited. Okay, so this is my last slide. What do we lack? We do not have syllabus. Undergraduate training is lacking. Everybody assumes that you know blood pressure. You don't. Postgraduate training, you don't. You ask a PG trainee, ask questions on hypertension, and they are not aware of simple things. So what we need to do is have diploma courses and home health education. So you need a professional education arm of a loop and the home health. Complete that and have the government buy-in, and that is how we can control things. So with a few change, we will move to the 4th guidelines, and hopefully we'll be presenting it in Hyderabad in September, hopefully, inshallah. This guideline has 20 cases, 22 cases at the end of the guideline, so it's a live document. You can read it, the answers are there. So I would encourage you to even go to the 3rd guideline and read it. And so with this, I thank you.